Hi everyone. Now we are going to solve all the questions of psychiatry which were asked in recent FMGE exam. Related to psychiatry questions, I would like to say questions were not so much easy and not so much difficult, but moderate level. Psychopharma, they have asked more questions this time. So let's see all the questions one by one. First question on mental status examination. 100 minus 7 equal to 93 test is used to assess which of the following mental function. Let's recall what I have taught you when I was teaching you how to assess higher mental function like attention, concentration, judgment power, abstract thinking. First of all, I have taught you DST, which is called as digit span test, which is also called as digit repetition test. Here I am asking my patient to count the number at the span of a digit. We can take the example of 2. So he will be counting like 2, 4, 6, 8, 10, 12, 14. If he can count up to 7 to 8 digits, it means his attention level is normal. So I can say that digit span test or a digit repetition test is especially we are using to assess the level of attention in my patient. All right. Now, higher level of attention is called as concentration. Higher level of attention is called as concentration. Now I'm asking my patient to subtract 7 from 100. Like this. After that, he is supposed to count up to certain digits like 93, 86, 79, 72, 60, 65. If he can count up to 7 to 8 digits, it means what? His concentration level is good. This test is called as serial 7 subtraction test. Serial 7 subtraction test, which is especially we are using to assess the concentration level. But out of these 4 options, there is no concentration level. What is the definition of concentration? Higher level of attention is called as concentration. So in this question, answer will be attention level. I hope this question is clear to all of you. Very easy question, right? Okay, question number 2. A patient is on treatment of depression, complaining of painful coitus, or some students have told me that there was sexual dysfunction written. So all these questions which I am discussing, these are based on the student's recall. Which of the following drugs should be started to improve his condition? Basically in this question, examiner is asking you, out of these 4 antidepressants, which one will be having least sexual dysfunction as the side effect? Or in the patient who was on the antidepressants suffering from sexual dysfunction, so which drug will be safe for him? Which new drug should be started for him? Let's discuss all the drugs one by one. First, option number D, escitalopram, which is an SSRI. What is the full form of SSRI? Selective serotonin reuptake inhibitor. Basically, with the help of this medicine, there will be increased level of serotonin level. I hope all of you know that whenever there will be increased level of serotonin, serotonin can affect some hormones as well as neurotransmitters. Serotonin can affect testosterone. Serotonin can affect dopamine as well. Fine. So in this manner, it can affect sexual function. Right? So as we know that on a long-term use of SSRI, delayed ejaculation is a side effect. Delayed ejaculation is a side effect. Apart from delayed ejaculation, patient can also have lack of libido. So yes, option number D, this SSRI should not be used, right? And now option number C, venlafaxine, which is SNRI. Here there will be increased level of serotonin as well as norepinephrine. So here also side effect is what? Erectile dysfunction, lack of libido, and there will be difficulty in achieving the orgasm, right? So this medicine should also be avoided. But the best part about this SNRI is that when the drug will be stopped, patient can get back to the normal sexual life. Option number A, imipramine, which is actually a TCA. There also, after you start a patient on TCA like imipramine, there will be increased level of serotonin, norepinephrine. Apart from these side effects, apart from these things, TCA also inhibit muscarinic receptor, histaminic receptor, alpha receptor, sodium gated, sodium of heart channel receptor. Because of this also there will be so many side effects. So overall, in this case also, with this drug also, there will be erectile dysfunction as the side effect. Fine. So option A and C and D should not be used here. Now option number B, bupropion, right? Bupropion, this is NDRI, noradrenergic dopamine reuptake inhibitor. Out of these four options, bupropion will be safest, which is having least sexual dysfunction as the side effect. Least. Fine. So safest drug will be what? Bupropion. I hope you know some more points about bupropion, that bupropion is also used as anti-smoking drug, and bupropion is used specifically in atypical type of depression. Bupropion we are also using for the treatment of ADHD, right? So yes, so this question is related to psychopharma. Next question, what is the common side effect seen after cannabis use or intake? Basically, examiner is asking what is the common effect seen after intake of cannabis, right? First important thing related to cannabis, this is the most common illegal drug to be used in India as well as worldwide. So you can use most common illicit or illegal drug. All right. See here, anxiety and decreased appetite. These two symptoms are seen in withdrawal from the cannabis, but examiner is asking just after intake of cannabis, just after use. So I hope all of you remember that there will be euphoria, excessive happiness, right? Euphoria, reddening of eye, slowing of time, right? Patient can also have depersonalization, derealization after some time. Patient can also have synesthesia. What is the meaning of synesthesia? Which is also called as reflex hallucination. Patient can say, I can watch music, I can hear light. So what has happened to the patient? In this situation, in synesthesia, there will be crossing of senses. There will be crossing of senses, right? Depersonalization, derealization, reflex hallucination. So basically out of these four options, best answer will be what? Altered consciousness with a state of dreaminess, right? What about option number D, physical dependence? Earlier it was said that there is no physical dependence associated with cannabis, but now as per the research, yes, there is physical dependence seen, but after very, very long-term use. So out of these four, answer will be what? Altered consciousness with a state of dreaminess. Yes, this can be seen after intake of cannabis. And one more point you please add here. See, when I say that anxiety and decreased appetite, these will be seen in withdrawal of the cannabis. But what about intoxication of the cannabis or after the use of cannabis? There will be increased appetite. There will be increased appetite. So easily you can rule out the options. Question number 4. Very big question, but easiest for you. It should be easiest for you. An adult patient is presented with complaints that he is talking to aliens, and aliens are sending radiations to his brain, type of somatic passivity. Okay, aliens are asking him to kill his neighbors. So basically he's having auditory hallucinations also. Family members are reporting that he has been suffering from this disorder for last 20 years. Patient is not going to farm and also not participating in any social gathering. But patient is well oriented to time, place and person. What is the most probable diagnosis? Okay, fine. Now you see all the options. Easily you can rule out. Option number 1, mania, which is a disorder of mood. Easily you can rule out this is not the answer. What about the personality disorder? You are not going to see these many psychotic symptoms. Obviously no here. Fine. But there is confusion between delusional disorder and schizophrenia. See, delusional disorder, first of all, this will be limited to a particular domain. And during the delusional disorder, hallucination will be absent or mostly it will be minimum. So delusional disorder, this is also not the answer, because here in this patient, almost all the aspects of life are being affected. So what are the criteria to diagnose hallucination? First of all, how much is the duration criteria? Symptoms should persist for more than 6 months. Here in this question, patient is having symptoms for last 20 years. Okay. Other protocol of like the diagnosis here, patient can have delusion, hallucination, formal thought disorder, motor symptom, or you can say patient can have catatonia. Fifth point, patient will have negative symptoms. Out of these 5, if equal to or more than 2 symptoms are there, okay, this can be a case of schizophrenia. Rule is that mixture of symptoms should persist for 6 months. Equal to or more than 6 months. And out of first, second and third, delusion, hallucination and formal thought disorder, at least 1 symptom should persist continuously for 1 month. See here, patient is having continuously hallucination. Easy to understand, right? So overall, first of all, whenever there will be delusion and hallucination, we can say that patient is having positive symptoms. In this question, patient is not going to farm. Patient has stopped working. Patient is also not participating in any social gathering. Basically, these are negative symptoms like avolition, right? Anhedonia, asociality, right? So patient is having positive symptoms also, negative symptoms also, right now. So here 100% diagnosis is what? Schizophrenia. I hope this question is clear to all of you. Fifth question, an alcoholic patient is on a therapy. Anxiety and fear were developing when he was exposed to a smell and taste of the substance, as he was punished during the therapy. Basically, this is a type of therapy where punishment is given to the patient. Which of the following therapy is given to this patient? First of all, rule out other options. Flooding, systemic desensitization, therapeutic graded exposure. See, option number A, C and D. Option number A, C and D. These are the therapies for treatment of phobia. Systemic desensitization, where you are giving behavior therapy plus pharmacotherapy. Therapeutic graded exposure, where you are exposing the patient to anxiety provoking stimuli and you are making the patient habituated to stay with the anxiety provoking stimuli. So this is only behavior therapy. Flooding, where you are exposing the patient to most severe form of anxiety provoking stimuli, that is called as flooding. So option A, C and D, these are for the treatment of phobia, behavior therapy. And now you see option number B, which is called as aversion therapy, which is a type of classical conditioning, and this we are using for the treatment of paraphilias and alcoholism, basically substance abuse. So what actually we do in aversion therapy? Okay, so see what is happening in aversion therapy. Patient is asked to imagine about unwanted behavior, and then suddenly a painful stimulus is given. So in this way, what is happening here? Association between unwanted behavior and painful stimulus is created, and the unwanted behavior is ceases. So this is a type of what? Aversion therapy. Since we are giving punishment to the patient, socially this is not acceptable, but this is a kind of therapy. So this question came here. Answer is what? Aversion therapy. Question number 6. A 25-year-old female having bipolar disorder is on lithium. Lithium has always been an important topic for the examination. Which of the following is wrong related to the drug interaction here? See here, thiazide increase lithium toxicity. Option number B, lithium decrease thyroid function. Option number C, lithium is avoided in pregnancy. Let's solve this question. Yes, lithium is a toxic drug. So we have to keep on doing therapeutic drug monitoring. As we all know that half-life of lithium is 24 to 36 hours. So we can keep 1.3 day, right? And so TDM can be started because it is going to achieve plasma concentration after 5 days only. So TDM should be started after 5 days only. All right. So yes, lithium can affect multiple systems in the body. Do you understand here that option number B, lithium decreases thyroid function? Yes. First of all, when it is mentioned here that a 25-year-old female, yes, patient is having higher risk because she is female, and lithium affects the thyroid function. It can lead to hypothyroidism. That's why after every 6 months, if a patient is on lithium, after every 6 months, thyroid function test should be repeated. So option number B is correct. Okay, now look at option number A. What is the side effect of lithium on your renal system? Lithium will cause polyuria. So it will cause secondary polydipsia. And finally, it can lead to diabetes insipidus. How to treat the patient? We have to give fluid replacement therapy. We can use thiazide diuretics. We can also use spironolactone, that is the potassium sparing drug. Okay, fine. So these drugs actually, how they help the patient? They are going to cause hypovolemia, and in this manner there will be reabsorption of sodium and fluid to the body. But we need to understand here that when we are using thiazide diuretics, what is the interaction of thiazide and lithium? See here, thiazide will decrease. Thiazide decreases lithium clearance. Very, very important. So this is suggested that whenever you are going to start a patient on thiazide diuretics, you have to decrease the dose of lithium. So what is happening here? Thiazide decreases lithium clearance. So this can cause more accumulation of lithium, and which can cause lithium toxicity. So option number A, this is also correct. Option number C, lithium is avoided in pregnancy. Yes, lithium is a teratogenic drug. And especially it should be avoided in the first trimester of pregnancy when there is organogenesis. So because of lithium, there can be defect in heart. There will be a disease which is called as Ebstein's anomaly. Ebstein's anomaly. So yes, lithium is avoided in pregnancy. But what about option number 4? Hemodialysis is not useful in lithium toxicity? No. Hemodialysis is the final management here. Please understand here that as we know that, see, more than 1.5 milliequivalent per liter, if there will be plasma concentration of more than 1.5, this will be the indication of lithium toxicity. More than 3 milliequivalent per liter, more than 3, there will be irreversible damage of nervous system, and this is 100% indication of dialysis. Means at any cost you have to do the dialysis to save the patient, because more than 4 milliequivalent per liter plasma concentration of lithium, of more than 4, patient will die. So dialysis will be mandatory in a case of lithium toxicity. So here wrong answer will be option number D. Now question number 7. All of the following are commonly seen in organic mental disorder except. See, in this question, some students told me, sir, actually framing of question was different. That is fine. Almost a similar question was there. How to differentiate organic mental disorder and non-organic mental disorder, which is called as functional disorder. Right now, functional mental disorder, non-organic mental disorder. First of all, let's understand how to differentiate these two. First of all, if you do radiological investigation, if you can see some changes, if there will be some insult of brain parenchyma, or changes in brain parenchyma, it will be called as organic mental disorder. No damage, functional mental disorder. Organic mental disorder, mostly it will be seen among elderly people. So what are the examples of organic mental disorder? Like delirium, dementia, amnesia, right? Elderly age problem. But functional, this can be seen in young age. Mostly this starts in the young age. All right. Organic mental disorder is acute in nature. Acute in nature means suddenly it will start. Okay, fine. But functional, it is slow and progressive. Slow and progressive. Now the question is that in organic mental disorder, when we talk about organic mental disorder, which type of hallucination is more commonly seen? See here, delusion and hallucination can be seen in organic mental disorder also, right? And in the functional cases also. So in organic mental disorder, when I talk about organic mental disorder, delusion and hallucination will be there, but only for short interval of time. Brief. But in a case of functional mental disorder or the non-organic mental disorder, when I talk about like schizophrenia, so there it will be constant and long standing. When I talk about schizophrenia, in organic mental disorder, when I talk about delirium, yes, there can be loss of consciousness, right? Now, see, in delirium, for sure, there will be clouding of consciousness. In dementia, it is not. But in organic mental disorder, when we talk, yes, there can be loss of consciousness. There can be clouding of consciousness. But in functional disorder, no. Now the question is that about delusion and hallucination. What is the most common type of hallucination in a case of organic mental disorder? It is visual. But what about functional? It is auditory. Now I think easily you can rule out. So in organic mental disorder, acute onset, yes. Elderly age, yes. Loss of consciousness, yes. It can be, right? Okay, fine. Most common hallucination, especially visual, not auditory. So in this manner, we have completed 7 questions. I hope you have done a great job in psychiatry. I wish you all the best. Thank you so much.